Hi, good evening. I'm Donatella Casilla, a consultant in diabetes. I'm going to introduce this evening a video about a very important issue in patients with diabetes. It's called hypoglycemia. Hypoglycemia means low blood sugar. And you can ask yourself why I'm talking about low blood sugar in a disease where usually it's associated about high blood sugar. So hypoglycemia can be a severe complication of diabetes medication and sometimes represent an emergency. So it's very important that people that take, especially those who take some medication, are aware about hypoglycemia. In my clinical practice, I see sometimes people who have been diabetic for many years, and when I ask them, do you have hypoglycemia? They look at me like I was talking about something weird. So it means they have no idea what I'm talking about after a long time disease. And of course I tell them it means low blood sugar, and I try to explain them what is hypoglycemia. So I hope you will find this video interesting, and of course I will be seeing you after.
Hi, I'm your glucometer, and I'm here to give you information about hypoglycemia. What is hypoglycemia? Hypoglycemia means low blood sugar. Your sugar can go low due to illness, certain medications, insulin, exercise, or skipping meals. Hypoglycemia is when your blood sugar drops below 70 milligrams per deciliter. You might be wondering, what is the typical range for people with diabetes? When fasting, which is 8 hours with no food or drink except water, the goal for your blood sugar is between 80 and 130. 2 hours after eating, the goal is less than 180. How do you know if you have low blood sugar? Finger sticks are the most reliable way to know where your blood sugar level is. Sometimes you might feel mild to moderate symptoms: sweaty, pale, shaky, dizzy or lightheaded, confused or disoriented, blurred vision, a fast or irregular heartbeat, vivid dreams, nightmares, or sudden awakenings. Sometimes you might have severe symptoms, like being unable to eat or drink, having seizures, convulsions, or jerky movements, or falling unconscious. And sometimes you might experience hypoglycemic unawareness, which means that your body doesn't give any warning signs that your blood sugar is getting low. This can put you at risk of severe, sometimes life-threatening, low blood sugar. Our bodies don't always give us consistent messages, so we can't depend upon experiencing symptoms to let us know that something is wrong. The only way to truly know if you have low blood sugar is to check with an FDA-approved glucose meter. How do you prevent hypoglycemia? Here are several tips. Eat meals and snacks on a regular schedule. Take your medications as prescribed. If your blood sugar is high, you may be tempted to take too much insulin or an extra pill. However, doing this is dangerous and could lead to hypoglycemia. If you are taking insulin or a medication that is known to cause low blood sugar, you should check your blood sugar regularly. Checking your blood sugar regularly and before and after vigorous exercise can help you catch a low before it becomes an emergency. How do you treat hypoglycemia? If your blood sugar is between 59 and 70, eating 15 grams of fast-acting carbohydrates can help bring your blood sugar back to normal. If after 15 minutes it is still below 70, eat another 15 grams of fast-acting carbohydrates. Once your blood sugar is in the normal range, between 80 and 130, eat a small snack to prevent another low. Fast-acting carbohydrates include 1/2 cup or 4 ounces of regular soda, not diet, 1/2 cup or 4 ounces of fruit juice, 1 cup or 8 ounces of skim milk. Hard candies. Be sure to check the label to see what serving size equals 15 grams of total carbohydrates. Glucose gel or tabs to be chewed for better absorption. Avoid having anything with chocolate, nuts, or higher fat dairy because fat and protein slow the digestion of the carbohydrates into sugar, so your blood sugar won't rise fast enough. Remember, It can take 15 minutes for the carbohydrates to raise your sugar. Try to stay calm and not overeat. What happens if your blood sugar goes too low and you are asleep or unresponsive? There is an emergency medication called glucagon that can be injected into you if you're unresponsive. Somebody who finds you unresponsive can easily inject glucagon into your body. Glucagon is a hormone that breaks down stored glucose, so glucose can enter your bloodstream and bring your blood sugar up. Your doctor will prescribe you a glucagon injection kit. Keep the expiration date of your kit written down and request a new prescription as that date approaches. Be open about your diabetes with family, partners, friends, and coworkers so they can help you if you need it. It is important that you show them where the kit is and how to use it. Wear a bracelet or necklace that says that you have diabetes. Keep a card in your wallet that says that you have diabetes and lists your medications. Set up an emergency alert on your cell phone to let people know that you have diabetes. To see a demo of how to do a glucagon injection, please go to www.bmc.org/glucagon. For the most part, hypoglycemia is preventable and almost always treatable. Stay prepared, keep your meter and glucose source with you, and if you feel odd, check your sugar. Sometimes low blood sugar and high blood sugar can feel similar, so it is important to be sure you are low before treating. If you eat because you feel low but your sugar is actually high, your blood sugar will rise even higher, making you feel worse. For more information, talk with your doctor, dietitian, nurse, pharmacist, and diabetes educator. They are all here to help keep you safe.
I hope you find this video useful and then you learn something about what hypo are. So I really strongly suggest that if you are having a frequent hypoglycemia or low blood sugar, you consult your doctor to have advice how to reduce. So it's not normal having hypoglycemia every day. There is something wrong with what you are taking, what you are doing. And I still see patients that come and see me and they have medication that are not good for them, and then they can sort this problem out easily. So now I'm here with Emma, and actually Emma has a history of type 2 diabetes and is currently wearing a sensor that, and she wanted to tell us her experience. Hi Emma, how are you?
Hi, good, thank you.
So Emma, how long have you been diabetic?
So I think, like a lot of type 2s, probably longer than I think. So I think that it's realistically is around 10 years. Mm-hmm. But from diagnosis, it's around 8 years.
Yeah. But you just mentioned before that you had some issue in the past with the low blood sugar.
Yeah, so I think particularly in the beginning, like a lot of patients, you probably go through a bit of denial. So accepting the diagnosis, and just going through a bit of a wild phase in the beginning. And like all patients, it was trial and error with my medications in the beginning. So my diabetic control wasn't great in the beginning. And I've also gone through periods as I've got older as well, where my medication has had to change. Like most type 2 diabetics, around 10-year period, we may be heading to the insulin bit, which is what I'm trying to avoid at the moment. Yes. But for me, I had very, very sort of textbook symptoms of hypo, severe agitation. I mean, I could feel it, getting really angry, annoyed, short-tempered, very restless, not able to concentrate.
You was aware that this was happening in your body?
I know for a lot of patients, they don't feel it, but I genuinely felt it.
So it's a very good thing.
I say I was lucky. I think I probably annoyed quite a lot of my colleagues at the time because they didn't understand why I was being a pretty mental.
Just give me something to
give me juice. Yeah, but as time goes on and you sort of learn what you should and shouldn't be eating, I've got significantly better at controlling it. But it's not a very nice feeling. It's almost like brain fog, almost like you're not able to concentrate or figure things out. And then the final stages for me, the worst I got was the blurred vision with sweating. So, obviously the next stage from that, I'm very, I say lucky, but I didn't get the severe symptoms with loss of consciousness, and coma. Basically, it can lead to death. But thank God I didn't get that. That's the worst symptoms that I got.
Perfect.
But yeah, not
so
pleasant.
Now we are quite lucky nowadays because we have more medication that are not associated with a significant risk of having severe hypoglycemia. So treatment has become more, efficient from this point of view. And in addition, there is a lot of awareness about the problem of hypoglycemia and the medication that can reduce the risk of hypoglycemia. But unfortunately, there are still a lot of people taking insulin. And as you know, one of the major risks of taking insulin is the risk of hypoglycemia. But I know also you do, you work with people with taking insulin. You work with the elderly patient taking insulin. Unfortunately, those elderly patients with a long story of diabetes are those who end up to take insulin. And can you tell us your experience with these people?
Yeah, I think, even as, as a diabetic and I'm a nurse, it's still everybody's story, if you like, is different. And there's no two people that have the same symptoms. But, I've worked with a lot of patients that are comatose. So I worked with ventilated patients post stroke where they weren't able to verbalize. They were diabetic, they were on insulins, but they weren't able to verbalize that. So, a big part of that was the training, the education of the caregivers and the nurses taking care of those patients. We couldn't get the traditional signs of hypoglycemia, so the monitoring was essential, knowing the patients that were prone, and being very mindful of any change of status, things like when people have infections, it really affects the blood sugar. If they're dehydrated, as an example, they have fever, really taking care of the diabetes. And then I've worked with, elderly in their own home, some in their 80s, 90s. I think the eldest patient I've looked after is 102.
Wow.
He had a degree of dementia, but he did have hypos. He was insulin dependent. So a lot of work with the families as well, with education and training so that they're able to manage the insulin regimes, but also the potential hypos as well.
In fact, as we saw in the video, a patient who developed a severe hypoglycemia, they can be treated with a medication called glucagon. But it's not going to be the patient to take a glucagon because he will be unconscious. So to instruct the family member to how to use and when to use is very important. So there's a lot of education there.
It is, and I think, you mentioned glucagon. When I moved to the Middle East sort of 15 years ago, that didn't even exist. So, a lot of these drugs, we're coming from very, privileged Western backgrounds where the drugs are available, but it's not always available. So it is that education part, speaking with the families, what they can use as a substitute, but more importantly, how they prevent the hypo in the first place. So I love the education part as a nurse, and a diabetic myself. I enjoy that part of it. And with better education, we get better compliance, and then the outcomes are much better for the patient.
Absolutely right. Today we are going to show you how to take insulin. It's a very short video because you will see that it's quite easy to take insulin. In addition, insulin or injectable medication are in the mind of people something difficult to do and painful or associated with a severity of a condition. However, there are new medications that are not insulin and they can be given early in the stage of the disease. They are excellent medication. And even if we need to give through injection, doesn't mean that is a severe medication. It's just that we don't know how to give this medication by pills. So I'm going to show you, we have a few pens today, and I will ask Emma to demonstrate for us how to take insulin or other injectable medication for diabetes. Thank you very much. Thank you, Emma.
Okay, so you will receive your medication from your doctor. So there's many different forms of injectables. These are just a few here, so I'll just choose one of them just to demonstrate. So as Dr. Donatella was saying, often, patients are actually really scared of injecting. They believe really the same things. It's a big needle, it's going to be painful, I can't do it on myself. So every person is different. Some people will just get on with it and, they have no fear, but others need a little bit more time and support. So generally, for those types of patients, we generally use some sort of dummy in order to teach them. It's just an orange. Some fancy, and he said hotels then, I mean hospitals. Hospitals will have like a demonstration dummy that they can do it with. But an orange is just as good because it sort of simulates the skin. Okay, so got the orange there. So we have the pen. When the patient has a new pen, they worry about the storage and things like that. They can be kept in the fridge, and they should be when they're unopened. But just before they're going to be injecting, they should remove it to room air, really, for around 15 to 20 minutes ideally. The reason for that is cold insulin actually stings a little bit, so it's much more comfortable for the patient if it's more at room temperature. So they'll get the pen like this. I don't know whether you guys can see here, but there is a dial with the number here. That's just indicates the amount of units of the insulin. And the doctor will obviously instruct you on how many units to be taking. And it's literally a dial that goes up and down that you would adjust. You've obviously got the main body of the pen. This one is the cartridge with the insulin. So when you take it out, obviously, you instruct the patient just to inspect it in case there's any sort of like clouding or anything. You can gently, if it's a mixed insulin, just gently mix it, but none of this. I see patients like just very gently tipping it, and then that will be fine. Have you got my needle? Oh, I wonder where it was. This is your needle. You will then you'll have like your own little kit. So this is the disposable needle. So these are sterile each time. So you just remove the cap here and then gently push and then turn clockwise. And you'll feel when it's tight enough. That's it for the needle. So we'll pretend that we're having 4 units for this one. So that's 4 units, okay? So preparation of the patient, in the hospital, they tend to use like alcohol swabs and things like that. I think, it's more of a dirty environment in a hospital, a lot more infection, obviously, than if a patient's in their own home. But prolonged use of alcohol swabs on the skin actually toughens the skin. So we don't recommend that in a home environment. Just that the patient washes their hands, obviously, so that it's clean. And then they can inject into which area of their choice. So another thing for patients, often they get confused by is like the injection site. Where do I put it? They worry that one area will be more painful than another area, and but really it's quite simple. Basically, anywhere where there's a bit of fat. Which sounds silly, but that basically is it. So the outer part of the arm generally is a little bit fatty on both sides. The thighs are great, and around the tummy area, not about sort of 2 fingers away from the belly button and in a circular movement. You can use your bum as well, but obviously that's not great for a patient trying to manipulate putting an injection. So it tends to be the front of the body. If they're using the abdomen, which most patients prefer, it's generally less painful. It's easy to access. We just recommend that they rotate the site because the areas can become hardened with, prolonged use in one area. So, and also absorption of the insulin can be affected. So we just tell them just to rotate with every injection. So pull the plastic cap off, but keep this one for later. We don't tell them to throw that away. And then we've already set the dial, as I said, for the amount of units that we need. We just remove the plastic end, which you guys probably won't see. I don't know how much that camera will go in, but it's a very, very fine needle. I mean, almost hair-like, you know, and when the patients see it, they're quite shocked most of the time. I think they imagine it to be this big fat needle that, you know, they see in the movies. It's hairline. It really is very fine. So when they first open a new canister, we do recommend that they just expel a little bit of insulin before they set. That's just to check there's no air or anything. But this one's already been set for the units. So imagine this is your tummy. And it literally is like holding a writing pen almost. So it's what's the word? It's a natural action to hold it in that way. We try and tell them to avoid this sort of movement because they can put too much force, but some patients believe it has to be a heavy injection. It's not. It's very smooth. It does not need to be heavy. So just that general gentle writing, and then we just literally gently put in. Very simple. One movement, and then to release the insulin, we just push. And then recommend that the patient counts to 10 while the needle is in there, just so that it's absorbed properly into the skin. After the 10 seconds, remove. So the last step, the reason we kept this one is so that we avoid pricking ourselves, basically, is to gently just put the cap on, and then you just do the opposite in rotation, and then remove and put. In a hospital, this would go into a sharp spin. In a home environment, we just tell them to use a hardened canister. So it can be a washing up bottle, it can be a Coke bottle, anything where it's the needles are not going to stick out to anybody else.
Emma, thank you very much. I think your demonstration was excellent. And I am sure and I hope that everybody has found this very useful. So for now, I will say you goodbye, and I hope to see you soon.